That brings us to session 5, our last session for today. I'll turn it over to Sharlene so she can walk us through this last session.
Good afternoon, everyone. So today I will be sharing an example dashboard to address the following key objectives for population health data management. One would be what key components of a performance dashboard are necessary to monitor interim outcomes. There we go. 2, how can we create, format, and use actionable reports? And so the actionable dashboard we will show today tracks interim results and can complement your practice's MDPCP CRISP reports. I'll go over the importance of population health data management. So you really have to know your why. For population health data analysis, we can use that to understand how a team is meeting the needs of their patient population in areas such as the volume of inpatient versus emergency department visits, cost trends, clinical quality measure outcomes, and other corresponding care team activities and efforts. Ongoing data review juxtaposed with implementing lessons learned can bolster efforts towards a more successful population health management model. And as Dr. Okeke already mentioned in session 2, please make sure you have a quality improvement process in place, such as using a PDSA model. And so as you review your data, you can identify areas of improvement and understand how to go about implementing changes. In this session, I'll only be demonstrating the data analytics portion of the process. So this session will be more relatable and applicable to the data analysts who are listening in. And so we understand that your data may be coming from various sources, which can lead to challenges in consolidating and analyzing trends. So it's crucial to be able to piece together the pieces to paint an overall picture of where your team is at and also what direction your team is heading. In this slide, I'd like to go over a recap of required steps. Dr. Okeke has mentioned this before. So first, you would need to identify measures to track, for example, claims data, activity log data, ECQM data, and other relevant data. Next, identify where your data sources are originating from. Is it from a specific portal, your EMR, CRISP, or somewhere else? Following that, develop a data collection process. So identify a data analytics platform and solidify a collection schedule that best suits your team's needs. And finally, enact regular performance reviews. So based on the data resources you've identified, your reports should be reviewed accordingly on a weekly, monthly, or annual basis. All right, so now that we have an overview of required steps, we will be taking a look at an example of an actionable dashboard that we can use to visually interpret data. And I will be sharing my screen. So in this example, we are using Microsoft Power BI as our data visualization tool. So no confidential information is shared in this demonstration. And we have 3 segments to this dashboard, which I will go through one by one. First, we have the episodic care management initial follow-up segment. So this segment tracks initial patient follow-up after a recent emergency department or inpatient discharge. And the key outcome is whether the practice successfully contacts at least 75% of their patients with a recent ED or inpatient discharge. The data source used for this segment includes CRISP ENS data and call outreach export data from an automated system. So on the first bar chart here, it's the automated follow-up by discharge type graph. And this just displays the number of automated calls to patients based on discharge type. So there's emergency versus inpatient discharge. Following that, we have automated follow-up counters for total encounters and the percent reached. So the total encounters are the number of automated calls to patients by the automated calling system. Of these 325 encounters in this example, the follow-up calls are initiated by the automated system, and 65% of those were successful or were reached. 65% of those patients were reached. The remainder of those were followed up using a manual calling system. And so below these counters are donut charts and a pie graph that breaks down automated call outcomes and manual call outcomes. So this includes whether the caller was sent to voicemail, whether a disconnection occurred, or some other outcome occurred. For manual follow-up, of the 35% that were not reached by the automated system, the care coordinator on the team initiates manual follow-up calls. So as you can see over here, 58% of the 111 manual follow-up calls were successful. And both the automated and manual outreaches are filtered into the total successful outcomes. And as you can see here, the total success rate was around 85%, which meets and exceeds the requirement threshold of 75%. Lastly, there's a pie chart that shows of the patients who responded to the question, was the encounter helpful? 85% of them responded yes. This is a nice way to gauge how the results of automated and manual calls to patients. I would like to bring your attention to the fact that this dashboard can have slicers or filters that can be applied to the data overall. So as your dashboard pulls data from over an extended period of time, you can analyze trends and use filters to delve deeper into specific categories, such as specifying data for a specific facility or practice, for a specific provider, or even for a specific week or day. The next segment is the longitudinal care management and phase 2 episodic care management follow-up segment. And this section actually relates directly to the key requirement of providing longitudinal care management for at least 5% of your attributed high-risk beneficiaries. So the data source used for this segment includes EHR encounter data and encounter log data, or service log data. And so on the left-hand side here, we have a counter for the eligible longitudinal care management beneficiaries. In this example, we have 250 eligible LCM patients. Of those we have identified, which would be greater than or equal to 5%. Here we have 25 patients, which is 10% of the active list. Below this are the total care management encounters, which includes encounters the care team does for follow-up beyond the initial phone call, beyond the initial follow-up. And so this relates directly to the graph I have right beside the counters. This would be the care management encounters graph. And this shows the encounters conducted by members of the care team that provide care management. And in this example, this would be for the lead care manager and the community health worker. These graphs are helpful to monitor as you determine the resources you may need for your patient volume, especially for high-risk patients. So as you can see in the first bar chart, the encounters are categorized into episodic care management follow-up, beyond the initial outreach, as well as longitudinal care management. And we can appreciate how the care team simultaneously does both. So filters can be, of course, again, just to mention, filters can be applied to display a particular type of encounter as needed. So you can look at episodic care management versus longitudinal care management, or both at once. Okay. I would also like to note that you can use your CRISP pre-AH tool to identify your high-risk patients to follow up with. And if you'd like to track that in these encounters or in the dashboard, you can update your main data source for the dashboard and then add in a filter and add in a chart as needed. The next two charts here show encounters by event type and encounters by care coordinator. So in other words, this would be whether the encounter was conducted by the lead care manager or the community health worker, as well as whether this was a call, a virtual visit, a home visit, etc. Below these charts are the assessment and care plan funnel charts. It's important that both the practice and their CTO ensure at least 5% of your beneficiaries, especially those who are high risk, have a care plan in place. So if you have resources to go beyond the 5%, you're encouraged to do so. So the funnel charts here capture the completed assessments and the completed care plans and intervention plans that are in place for patients. What you would like to see here is a less defined funnel, so a more rectangular shape as opposed to more funnel shape, which means you are meeting the needs of your active patient population for longitudinal care management in terms of assessments and care plans. As Dr. Okeke mentioned earlier, there is movement of patients in terms of longitudinal and episodic care management needs. So as long as you have a set goal and you monitor your performance, you should be good to go. The last segment of this dashboard is the ECQM segment. The data source used for this segment is clinical data from your EMR. First, you need to define your ECQM measure, and these measures can be found in the MDPCP reporting guide on Connect, for example. These measures are based on the numerator and denominator and exclusions for each ECQM. In MDPCP, you should focus on hemoglobin A1C levels, hypertension, and the initiation and engagement of alcohol and other drug dependence treatment. Those are the three main ECQMs you should be focusing on. For hypertension and hemoglobin A1C, those are pay-for-performance measures with specific benchmarks at the 30th and 70th percentiles, whereas for the drug and alcohol use, that is a pay-for-reporting measure for performance year 2019, so there were no benchmarks currently. So here the counters actually display overall aggregate performance across an entire practice, so for multiple providers. So this is the average performance for all of them. The light green box indicates that the 30th percentile benchmark was met, whereas the darker green box indicates that the 70th percentile was met. And below these counters are two different graphs and two different ways you can display ECQM performance data. So the first one shows trends for a specific provider over time, and the second one shows trends based on the specific ECQM measure that can also be adjusted based on a period of time. So you may choose not to have data labels in order to reduce clutter. However, in this particular data analytics platform, you can hover over the lines, which will show the specific data points. and you can delve deeper into any next steps or any further discussion. So I would like to highlight that you should try and make your reports dynamic and not static in order to help guide conversations and drill downs when you need to review reports as a team. And again, the dashboard is an overview that provides actionable data. Beyond this, we can delve into next steps. So for example, a list of patients who have not met each ECQM measure can be distributed to providers, and then they can use that information to further build upon any future plans and build upon any tools for next steps. And to wrap this up, please remember that the data analysis approach will vary from practice to practice. We've just demonstrated one way you can think about staying on top of your performance using data. And we would like to reiterate that ongoing data analysis is important in identifying areas of improvement, meeting requirements, and bolstering efforts towards a successful population health management model. You should be able to piece together data from multiple sources in order to paint an overall picture of where your team is at and what direction you're heading, as well as how that compares to overall averages with other MDPCP practices and state averages. So thank you for listening in on the population health data analysis portion of today's presentation. And I'll be here for any Q&A, but I will send this back over to Angelica.
So that ends our all of our training sessions for today. Right now, we will conduct a Q&A. We do have a couple of questions that came into the chat box that we want to address. Hopefully, we can get to all of the questions. So let me go ahead and kick us off. I know we don't have that much time. So the first question that came through is for Dr. Okeke. So our team has gone through a series of workflow changes since we started the MDPCP program. What is a reasonable number of times to test a change before actually being ready to implement?
Wow, that's a tough one. There is no set number. And I think what would help is how thorough you are at the beginning. So you are not kind of taking shortcuts and therefore not fully thinking through your tests of change. And therefore midway you realize, oh, I should have thought about A, I should have thought about B. So I think what would help is to first of all, put in a lot of effort at the beginning in the planning, because everything else would kind of go more smoothly if you do so. So again, you have the template for PDSA, pull that down, sit down as a team and think through those 3 questions, set your aims, identify the measures you're trying to track. As now you've seen the dashboard demonstration of there's some interim outcomes that you want to know about that sort of feed into the final outcome, be it the final ECQM performance or utilization and things like that. So be very specific about what the scope of your test of change is, and also then identify what are the different initiatives that I could apply or implement. And most often you have 2, 3. So which one is the best to start with and why? Have you discussed this with the team? At least 2, 3 people in the practice to get feedback. Also, don't forget, you can also run this by your patients who are part of the PFAC. So when you do that initial heavy lifting, then it's easier to kind of understand where you're going, when you're collecting data and measuring, you kind of understand what to tweak or what not to tweak. So if you do it that way, worry less about how many iterations you have to go through, because you're doing exactly what you need to do. Depending on the size of your practice, the more the practice staff and those involved, you have to give some patience. We talked about change management, we talked about team-based care quality improvement. Everybody's still at different levels of understanding or positioning for these things. So also keep that in mind, that can impact how often you test the change or how far along you move. I hope that was some insight into things that you can consider or think about as you continue to embark on your change journey.
Great, thank you. All right, so another question that we had come through is, how do you do analysis of payer reports via CRIS for small practices?
Interesting. I would advise, first of all, to think about the CRIS reporting for utilization and cost in a quarterly, in a quarterly way or quarterly basis, because at least from my experience with the payer side of the house, you have what you call a completion factor, which means that if you think about it, every time you actually went to the hospital or the ED, you can remember how many times you got different bills, right? So one came this week, one came 2 weeks later, one came a month later. So you have to give time for all the claims or the billing that went in for that episode to kind of be all accounted for, because there are different providers all involved. So we have a completion, what we call a completion factor, which is about 90 days, to give that window to make sure that all the billing and claims that's related to that particular episode is all already in place to the payer. In this case, it's CMS. So once that happens, then you can look back and see what the other information you can glean from that in terms of utilization and associated cost. So when you use your CRIS report, my advice to you would be start small. Now we are in May. Most of the information for Q1, which is January, February, March, should be in. And they do, again, if you go and look at the link or the different recordings for using your CRISP reports, it will show you that as well. But it does indicate if there's, the completion factor and the status of that. So, if I'm looking at it this month, then I should be looking at a more complete report, if I'll put it that way. So look at how you performed. The dashboard that Sharlene had just reviewed is also being tracked by month. So one way it would be helpful is to go back and look at your Q1 interim dashboard to say, okay, how can I overlap all the effort that was going on with episodic care management, longitudinal care management, and how does that kind of align with the trend that we are seeing in cost, in utilization and cost, because we're hoping that there is sort of an inverse reaction that should be happening, relationship that should be there, right? So the more we provide longitudinal care management for our patients that are high risk, as well as be on top of episodic care management, then we should see an improvement in avoidable hospitalization and utilization, and therefore cost. So really that's something to keep in mind. And as long as you're doing that on a quarterly basis, yes, it's retrospective, true, but it still gives you a snapshot of an overview for every quarter, and you have at least 4 quarters in for the year. But because of that lag in the reporting from claims data, use tools like your pre-AH tool that's updated on a monthly basis, which is helpful for you to kind of know who your at-risk patients are. And then eventually, if you have a way to track your interim performance, whether you're using a spreadsheet, simple bar charts in a spreadsheet, Power BI is really backed by Microsoft, which is also the same application that gets family with Excel. So whatever it is you choose to use, remember that measuring in the middle, measuring what's happening in the interim is always helpful to compare on a long-term basis what is actually happening over the year, and that's what you also see in the CRIS report.
Thanks, Dr. Okeke. All right, so the next question we have, this one's for Ashley. Can you explain how the CHW works closely with the care manager, and do they document in the EMR as well?
Sure. So thank you for the question. The CHW actually works in tandem with the CM in most cases. Social determinants of health are typically assessed. Resource needs are still shared, as with all CHW work, but the CHW typically joins the CM from a care team perspective, and they round regularly to meet all care needs. Rounding typically happens face-to-face with the patient's care team, but of course, due to the current circumstances, a lot of rounding is being done telephonically, either through telemedicine with Zoom,
But rounding is certainly still happening as it pertains to the CM-CHW collaborative. So thank you. And I'm sorry, yes, the CHW does typically document in the EMR. They typically would document under what appears to be a non-clinical coordination type of note, and basically just summarizing their findings from their assessments and the resources that were shared, as well as their next steps in how they will continue working with their patient to meet all of their social needs.
Thank you, Ashley. So the next question we have is for Sharlene. So how long does it take to identify the data sources and then create a report like you just demonstrated?
Thank you. Thank you for the question. So that's a good question. So for a dashboard like this, approximately 2 to 4 weeks, give or take. This is highly dependent on how readily available your data sources are. And you have to factor in time needed for formulas, for formatting, nomenclature, and other troubleshooting. And also, I would like to bring up the fact that this is a group effort with multiple iterations and rounds of feedback, which should speed up the process, but approximately 2 to 4 weeks, give or take.
Great, thank you, Sharlene. And don't go too far. We have another question about the dashboard. All right, so someone had to step away, so they missed what the name of the dashboard was that you were showing. So the question is it proprietary, homegrown, or being sold or shared?
So the analytics tool we were using was Power BI, and that's a Microsoft-based tool. There are other tools out there, of course, but aside from that, we can definitely follow up and provide you with more information through the PMO in terms of other resources, for example. I hope that sufficiently answered that question. There isn't a specific name to the dashboard I shared because it was an example dashboard, but the tool itself was Power BI.
Thank you so much, Sharlene. So I know there are a couple of other questions that came through. And just for time's sake, we do have a couple of minutes that we want to go over some reminders and then also close off on the closing remarks for this session. So apologies if we did not get to your question. We'll take a look at those questions and also address them and get the answers to you some sort of way. All right, so with that said, that concludes our Q&A session. So I want to thank everyone so much for attending the webinar. Also want to give a special shout out to our presenters for providing this wonderful training. So we hope that you found the training sessions and topics helpful. The session was recorded, so the recorded session will be ready in about 7 days so that you can share with others within your organization. Before I turn it over to Dr. Okeke for the closing remarks, there are a couple of other things I wanted to provide a reminder on. So once we conclude the training, there will be a survey that will pop up as you exit GoToWebinar. Again, please take some time to fill out that survey. It's only about 6 questions. We really want to know if this training was helpful, and also if you could provide any additional topics that you may want to see in the future for training sessions. That would be much appreciated. You'll also receive a follow-up email including instructions and a link to apply for the CME credit for this training. Again, for those that are not physicians, you can apply. Just make sure to check with your credentialing organization if they accept the CME credits. So that's all I wanted to provide reminders to everybody about. I'll turn it over to Dr. Okeke for additional closing remarks, and I hope you have a wonderful weekend.
Okay, thank you, Angelica. To everyone who participated, I want to say thank you, but I also want to say thank you to you, Angelica. You've been a wonderful host, and we appreciate your time and your effort with this. I also want to thank Dr. Haft and his team, Chad Perman, as well as Tommy Liu, and the entire faculty team who really worked hard behind the scenes to bring you this training. Most of all, You guys are definitely our dear primary care heroes. Thank you for being here, and it's humbling to see the dedication to really come here and see what you can either share or learn more about to keep raising that bar for our patient care delivery in the state of Maryland. So thank you, and thank you.
That concludes the webinar for today. We hope you enjoyed it and have a great weekend all.